Morning, Chris Ohl, Wake Forest School of Medicine, Infectious Diseases. Happy St. Patrick's Day. Believe it or not, our third St. Patrick's Day being shared with COVID. So we have a special COVID update this morning. I have a special guest, Dr. Trey Bateman, who's with the Department of Neurology here at Wake Forest School of Medicine. He is graciously agreed to come talk to us this morning about some of the neurologic issues that can go along with COVID. We get a lot of questions about that, and it's a deep issue, and so we will be chatting in a little bit after I give us a brief update about where we are. Right now, I first would like to say a special hello to Linda and all my friends up in Eden, North Carolina. This is where Dr. Bateman hails from, and beautiful city on two beautiful rivers. If you've never been there, go check it out. It's a pretty cool place. So where are we going right now with COVID? So here, we'll start here locally. In the Triad, our cases are still coming down. So we're roughly running about 8 per 100,000 per day, which is about the lowest point we've ever been. Pretty similar to where we were at the end of last June, if you remember that time, right before Delta came up. And so that's a very comfortable number. If you're looking at the CDC charts, we're still in the yellow range, and as I have talked about a couple times, we probably will stay that way because we have a lot of acute care hospitals here in the Triad, specifically here in Forsyth County, and we have a fairly low population in Forsyth County compared to the number of hospital beds we have, and since the number of occupied hospital beds with COVID now factor into the CDC's color scheme for risk, it brings ours up. Meanwhile, if you're down in Charlotte, where your rate is also roughly at about 8 per 100,000 per day, you have more people in the city of Charlotte, that means that the bottom of the fraction is higher, so that the fraction becomes lower, and they're in the green zone. So good for you down in Charlotte. Here in North Carolina, our numbers are also relatively plateaued out, kind of in this low range. We're running about 3.3% positive for our testing in the area. Not a lot of tests being done right now, but that might pick up a little bit. So across the country, I would say we're in a quiet time. We're in a sweet spot with COVID, and it's a good time to enjoy that. Now, there's been a lot in the particularly the print media of late about potentially a harbinger of problems in Europe because their case rates are going up some there. So I just want to put that in perspective a little bit. And yes, in some countries in Europe, cases are going up. But there are also some countries in Europe where the cases are still coming down. So notably where the ones that are going up the German-speaking countries, the Germanic countries, Switzerland, Austria, Germany, Luxembourg, Liechtenstein, and then the UK and Ireland. Meanwhile, Spain and some of the other countries, Denmark and the Netherlands, are coming down. So this has been kind of saying, well, why is this happening? And it's multifactorial for some of these countries. As we've talked about for 6 weeks now, we've been following the, quote, son of Omicron, the BA2 variant of Omicron, which is one that has a few different mutations than the original parent of Omicron. And I've said in the past, it's a bit more infectious, and so it can gain a little bit of an advantage in a large population. But if for you as an exposed person, or for you and a family, it's not that much more infectious than Omicron itself to make much of a difference for you. But that's been brought up as a potential reason for increasing cases. Personally, I think it's probably more that most of these countries in Europe really took their masks off, gave up social distancing. In fact, gave up almost all their restrictions. And that's going to increase cases some, just because there's more of an opportunity for transmission to occur. And then lastly, it's been postulated that there may be some waning immunity from vaccination, including the original vaccine series. And that's probably contributing a little bit too. The one thing though is I think you can't lump all of Europe together and say that's what's going to happen to us here. For instance, if you look at Denmark and the Netherlands, so Denmark's rates started going up at the same time the UK's rates and Germany's rates were coming down. And the people in Denmark said, well, you know, we're not going to lock down again, we're not doing restrictions again, because our deaths and our hospitalizations really haven't gone up much. And so the impact of it doesn't seem to be that high. Their case rates in Denmark at one point were up to 500 per 100,000 per day. Again, I said we were at 8, so they were having a lot of COVID cases diagnosed. But it didn't really, the impact on it on their society wasn't huge. It really wasn't a big problem. And now their cases are starting to come down. So they ended up having a bit of a post-initial Omicron wave that was smaller, but yet less impactful. The other thing you have to realize about Europe is that this is a place where it's really easy to get tested for Omicron. And so you can walk into just about anywhere and get a good test. And it's become sort of the cultural standard now in Europe that if you got a cold, you get tested for COVID. I don't think our testing rates are as high here in the United States. Well, I know they're not. And so they're going to catch more. And most of the COVID that they're catching are breakthrough infections in vaccinated people. We've been calling COVID colds, and really aren't all of that meaningful for the individual's health or for the health of the population. So the long and short of it, how concerned am I about the BA2 variant? We're seeing more of it here in the United States. Interestingly, it hasn't caught on as fast in the US as it did in Europe. Some places in the US it's about 25%. Here in our area in the Triad, it's probably somewhere around between 10 and 15%. But I really don't think that this is going to be a big problem for us in the future. I also want to remind people, as I've been saying all along, that COVID is not over. So I was asked the other day in the grocery store, Dr. Ohl, when is COVID going to be over? When will it be over? And my response was, it'll be over when Tom Brady stops playing football. And as you know, he's back to playing football. So I guess it's kind of like we'll let Tom Brady be our COVID groundhog. So we have in store some more COVID in front of us. I still think that the worst is behind us. I think that the January wave is the worst we're going to see for the sheer number of cases, and I think Delta was the worst as we're going to see for severity of infection and numbers of deaths. And so anyway, I haven't changed my tune on that. We are going to continue to live with COVID in a way that's a little bit different. Will our masks have to come back? Well, you know, I think a lot of it's going to be individual, just like it is right now. If you want protection, if you have an underlying health condition, if you're older, if you are immunocompromised, you probably want to be wearing a mask. Will we be doing it for the entire society? Maybe we won't need to. Maybe we'll mask the people who need to be masked to protect themselves. One thing that we really, I think, is going to be a big difference is antiviral treatment for COVID, and we're seeing that open up more and more and more now. So, and at some point, will be some pharmacies will see it that if you get a positive COVID test, you'll be able to get your antiviral drug, your quote, Tamiflu for COVID, at the same time. But I think that that this is going to help us move into a period of endemicity. So COVID's not over. We're just going to change, and the way COVID impacts us and how we think about COVID is changing. And that, I think, is still an optimistic good thing. One study I want to talk about before we turn back to Trey is, you probably saw this week that Pfizer put in for an FDA emergency use authorization for a 4th dose of their vaccine. What does this mean for us? Well, the FDA is going to look at it. And then even more importantly, after the FDA weighs in on it, the CDC and the ACIP, which is the Here's How to Use Vaccines in the United States Committee, will tell us what we should do with it. The FDA will probably authorize it. I mean, the vaccine's safe and effective, and antibody levels go up after the 4th dose. But what we really need to know is, does our population as a whole need a 4th dose of vaccine to keep us out of trouble? And right now, the data, it shows, most of it shows that it is. And even for Omicron, having 2 shots and a booster was 91% effective against serious infection, hospitalization, and death. That's come down a little bit, but it's still around 80, low 80s, and that's pretty darn good for a vaccine. So there may be some people where a 4th dose would be useful. Right now, even as we speak, if you're immunocompromised, you should get a 4th dose. And maybe, our older population, those over 70 or so, might have a 4th dose coming down the pike for them. But I really am not sure that we need a 4th dose for most people right now. Next fall is the big question. Will we get a booster, just like we get a flu shot booster before respiratory viral season? And will that COVID booster just be the same old COVID shot we've been giving, or will it be one that's more specific for the Omicron type variants or for another variant should one come along? We'll have to see. We don't have enough data to know about that yet. But we got some time to think about that. November is a ways off. So with that, let's talk a little bit about COVID and the brain.
Okay.
And Trey, you're a brain guy, right?
I am. I'm a behavioral neurologist here at Wake Forest.
Now, what is a behavioral neurologist?
So a behavioral neurologist is somebody who has primary training in neurology and goes on to do additional training in, the full name of the fellowship is Behavioral Neurology and Neuropsychiatry. And so we focus on the intersection and the sort of the gray zone or the border zone between neurologic illnesses and psychiatric illnesses, with the idea that all behaviors have a brain correlate.
I see.
And so in practice, we end up seeing a lot of folks who have cognitive troubles, dementia, Alzheimer's disease, traumatic brain injury, and the like.
Cognitive meaning difficulty thinking,
memory and
brain
thinking,
function,
yeah.
memory problems.
Memory and
cognitive.
thinking is a good way to put it.
So you use the word psychiatric in there, which sometimes turns people off a little bit. Do you want to expand on that?
Yeah. So I think that we use the term psychiatric often to refer to behavioral and emotional changes that people have. But we see behavioral and emotional changes in all manner of brain diseases as well. So after stroke, as a consequence of Alzheimer's disease and dementia, things that people would not sort of have that same negative stereotype about psychiatric changes, they still have behavioral and emotional changes as a consequence of those brain disorders. And so I end up seeing and treating a lot of those manifestations of primary degenerative diseases of the brain.
Yeah. So it makes sense, because our personalities, who we are, how we feel, how we think, is done by the brain.
Yeah.
And so if the brain has some loss of function, then those things will change too. It's just part of it. And I know a lot of people probably have seen this in their own loved ones as time goes on or after an illness.
And
they think a little differently.
I tell patients that, it's no different than lifting your arm, right? I see people who have strokes who may have severe apathy or even psychosis after a stroke. And that's no different than somebody after a stroke being paralyzed on one side of their body. The difference is we all like to feel like we somehow have more control over our mental functions. And so it's a little uncomfortable to recognize that but for an intact brain, we could all experience a change in our personality, a change in our ability to perceive what's going on around us.
Right, yeah. So let's bring up something, because that really got a lot of attention lately. And there was a study published in Nature, and for those of you who don't know, the medicine scientific journals, Nature's right up there. New England Journal, Nature, and these are ones that you get into that journal, we pay attention. And so this study looked at people who've had COVID, and then looked at scans, right, afterwards, to see what their brains were like afterwards. What were the main findings from this study?
Well, and the thing that was so important and convincing about this study, we've had a lot of studies that have sort of taken people who've had COVID, scanned their brains afterwards, and looked for differences. This was the first study that I've seen that had people who were in part of a study going on over a period of time. They had a scan, and then they were going to have another scan. Well, about 400 of those people between those two scans had COVID, most of them mild cases. And they had another 400 people who had those two scans but didn't have COVID between the two.
So the first time they got a scan for some other reason, or
just part of a study. Yep, just part of a study.
They hadn't had COVID yet,
exactly.
And then they got a scan. And then they got COVID, which was just unlucky for them, and then they got another scan.
And so what it found, it did find structural differences in the brains of people who had mostly mild COVID. And intriguingly, it was sort of in the areas where we might have thought you would see it. So there's been a lot of talk of the smelling system and the olfactory system with COVID. Early on, people will remember that everyone was losing their sense of taste and smell, and that part of the brain is very intimately connected to the older parts of the brain called the limbic system that are responsible for emotion and memory and things like that. And so what this study found was a very small but real reduction in volume of those areas that are connected to the smelling system in the brain. It was a fairly small difference, on the order of 0.3 to maybe up to 1% difference. So
that sounds small.
Yeah.
Yeah.
And it's real, but it is small. And to put that in perspective, remember, scans are sort of, we're making some presumptions when we do those scans. We like to think of them as sort of perfect arbiters of reality. There's a lot of things that change what we measure on scans. So to put it in perspective, people have looked at, well, if we do a scan in the morning and then we do a scan in the evening of the same people, do we see a difference in their brain volume? And it turns out we do see a difference in their brain volume. So just the time of day can impact a small amount of volume in the brain, a similar order of magnitude to what we're seeing here. Now these folks were all sort of scanned at different times throughout the day, and so I think it's a real change, but it is, relatively speaking, pretty small.
Yeah, but because they had so many, 400 and some,
Yeah.
you can maybe say something.
Yeah, and I think it's real. I think it's there. What we don't know is what happens 3 months from now, what happens 6 months or a year from now. It's certainly possible that those lines will sort of stay apart. It's also possible they may come together and we won't be able to see differences in brain volume.
So it could be
after that.
temporary.
It's possible.
Yeah. So, what does all this mean, though? So you say it's particularly in the areas where the smell, and so, for those people who had neurology 30 years ago, like I had, the smell and emotions tend to be kind of in the same area in the brain. Mm-hmm. So what does that mean for them? Does that mean they can't smell anymore, or that they behave differently?
So it could mean that for some people, right? Some people have had persistent trouble with smell afterwards. Some people have had it and it gets better again. People certainly experience changes in the emotions they experience, how they experience emotions after a COVID infection. The problem is a lot of things cause those differences in how we experience emotions, and so being able to link it specifically to this is caused by that infection is really challenging scientifically.
Yeah, I would agree. So everyone knows I had COVID last August, and I lost my sense of smell and taste for a few days. Came back as far as I could tell. And so if I forget to pick up the milk on the way home, can I blame COVID for it?
I wouldn't. I've not had COVID yet, as far as I know. And I also frequently forget the milk on the way home. And so, a lot of the things that people will have concerns about maybe a normal experience. Our memories are not perfect. Our attention is not perfect, and one of the concerns is that while there are likely people who are experiencing very real structural changes to their brain and body leading to symptoms after COVID, it's also exceedingly likely, based on what we know about the human brain and mind, that there will be people who begin to place more emphasis and import on those normal memory lapses, and may think with studies out like this, oh my goodness, this is now a really significant event, and because my brain has an injury.
So is it normal for somebody to have more memory problems as they age? Just, without having a disease or dementia, but is that normal?
We talk about sort of healthy cognitive aging, and if you draw it out on a graph, there is a downward slope. It's not huge, but we do see changes in what's called, often sort of goes under this heading of fluid intelligence, so the ability to think quickly, to multitask and things like that. We do see some decline as people age, and when we do testing in clinic, that's the reason we take into account age and education level, because age does absolutely impact how people perform.
Huh. Yeah, I was taught by a neurologist back in the day that our brains are plastic, and that people tend to think of the brain as what you get is what it is, and but it seems like that he was right.
They change for better and for worse.
Yeah. So can the brain, can one part of the brain pick up and take over from another part of the brain if you lose some in that area?
Absolutely, and I think we see this most convincingly after things like stroke and traumatic brain injury, when we see people who have very clear, very sometimes large areas of their brain that have not just temporary injury, but cell death. Parts of the brain die. And when that happens, sometimes in 3 months, 6 months, people with who had previously had fairly significant deficits you may not be able to tell, or you may only be able to tell if you do very precise testing, and it's certainly recovered more than it was right after the injury. That's really the entire basis for rehab, stroke rehab.
So let's shift gears a little bit to talk about what this might mean for an individual. So I had COVID last August, lost my sense of smell and taste. So should I get a scan?
No. This is not something that, so I look at brain scans most days of the week when I evaluate people who have cognitive disorders, memory and thinking disorders, and I would not be able to see any of this with my eye. This was the way that they found these differences is by using pretty sophisticated computer programs that very precisely outline the areas of the brain and then calculate the volume of those areas. Wouldn't be clinically apparent.
So I got it. So I shouldn't get a scan right now.
I would not order one.
All right. So who should see? What kind of symptoms do you see that might be attributed to the neurologic system?
Yeah.
After COVID.
So I think I sort of break this down into two time periods. There's the acute symptoms that you see with COVID that can be neurological, and those are mostly pretty obvious. With any infection, people can get confused, a delirium. People can develop. We've seen an increase in strokes, especially in younger adults. COVID seems to really do a number on the clotting system in some people.
Yeah, and it's not just the brain that takes the hits sometimes either. So.
And we've certainly seen people, in the hospital who, have COVID, have no reason to have a stroke that we can identify other than that, and they've got clotting problems throughout. So that's certainly a possibility. Sort of in that subacute period, getting away from the initial infection but going out to weeks and months, we've seen some cases of what's called Guillain-Barré syndrome, which is really just your body starts attacking the nerves as they leave the spinal cord and can cause people to develop weakness.
Which you can see after a lot of infections, by the way, because even things as infectious diarrhea can cause that.
Absolutely. Same with delirium. There's nothing unique about COVID with regards to that. We see that after lots of infections. But as we move into the chronic phase, this is where it starts to become a little more difficult to determine the cause of the symptoms, and but the things that we are hearing about and seeing in the post-COVID setting, headaches, dizziness. Some people are developing a syndrome of dysautonomia, or the part of your nervous system that controls things like blood pressure, heart rate. Seems to have difficulty regulating that. So people will develop,
racing hearts.
Racing heart. They may stand up, feel like they're going to pass out, and it can be quite debilitating for people.
All these things sound rare, though.
These are pretty rare, and that's the other thing to keep in mind here is that the vast majority of people, after they've had a mild COVID infection, do recover.
They're fine.
In many ways it sort of parallels the concussion world, which is a place that I live. Lots of people have concussions, and by and large they recover pretty well. Maybe have some early temporary symptoms, but for them, in large part, they recover. But there's a small number that really have quite severe persistent symptoms that occur after the concussion or after COVID, and then figuring out is it due to COVID, is it due to something else, can be tricky.
So should you see a dive? So let's say you had COVID, 3, 4, 5 months ago, and now you're having what you think is more of a problem with headaches. Everyone gets headaches, but so they seem to be more severe. They seem to be worse. When should a person see their doctor for that?
So I would tell people who have this after COVID essentially the same thing that I would tell them if they had never had COVID. There's nothing unique about headaches after COVID per se. You don't treat it differently. So if headaches are increasing in severity, if they're persistent, severe, and especially if they're causing impairment in your day-to-day life, very reasonable to see a doctor about that, because may be able to help.
Yeah, I mean, even if it's just a migraine,
Exactly.
get something for that. Makes sense. Let's at the last part here, talk a little bit about what people call long COVID, which, by the way, the real term in medicine is post-acute sequelae of SARS-CoV-2 infection. Not surprising that that term hasn't caught on. But are the neurologic issues with long COVID, or are they what's responsible for long COVID, or what really is long COVID?
I think one of the mistakes that sort of gets made is this tendency to lump long COVID into a single thing. I don't think there's compelling reason to believe that every patient who experiences symptoms after COVID has the same thing. I think there are probably multiple different sort of presentations of that. And some of them, there's some early research looking at sort of brain fog that people will describe, that commonly, that'd be thought of as sort of a neurological thing: difficulty thinking, difficulty concentrating, difficulty with attention. And there does seem to be some individuals who have changes in the fluid that surrounds the brain that can be associated with that. There was a study out of in San Francisco recently that looked at that. At the same time, brain fog is not an uncommon thing for people to sort of complain about with outside of COVID as well. And so in some cases, it may be related to sort of a primary neurological or brain issue. In other cases, people come in and they're just really fatigued.
Yeah.
And that fatigue is really the cause of the brain fog, which is important to tease out, because fatigue is very different from just isolated brain fog without feeling tired, because you can treat fatigue a little bit differently.
Yeah. I think you're right. I mean, as an infectious disease doctor, we've, since my first days of being a doc, I've been referred patients with what have this post-acute sequelae syndromes, where it really seems like they had an infection, or they had some event in their life or something that was different, and then they have this prolonged fatigue dominating illness afterwards, with brain fog and such. So it's not just COVID. In fact, I did some looking at it, and some of this was described actually all the way going back to the Civil War.
Really?
In World War I. Yeah, so it's been around for a long time. We used to have an entity in infectious diseases called chronic brucellosis, post-brucellosis. We don't hardly see brucellosis anymore. It's an infection you get from animals, but it was common in the 30s and 40s, and it was described then. And so, it always seems like there's something that this gets linked to, and right now it's COVID.
Yeah.
But I really, it's really hard to sometimes to help patients with it. But there's always something you can do that make people feel better.
Yeah.
So what would you do if, say, I had COVID and I'm having a lot of problems with what I think is brain fog. I just don't feel like I'm thinking well enough, and maybe my wife says, he just doesn't seem quite the same. He's not as sharp as he was. And I come to see you. What kind of tests will you do on me?
So if you come in complaining of those symptoms, I probably will get a brain scan at that point. I would almost certainly get some really detailed cognitive assessment. A lot of the things that your physician will do at the bedside in the room, they're pretty crude assessments of memory and thinking. So I would probably ask my colleagues in neuropsychology to see you. And the reason for that is that they're the ones who do really detailed cognitive assessments. And what's important to understand there is, do you have objective declines in your memory and thinking, or are those scores normal, but you're still experiencing day-to-day difficulties or perceptions of difficulties with your memory and thinking. And it's not to diminish people who have those normal scores but still have problems, but it tells me something different about the brain, right? If you have these sort of objectively low scores, that sort of puts things in a different category of really worrying about more of a primary memory disorder versus if you come in telling me that your scores are all normal, then I'm going to start looking for how are you sleeping? Could you have sleep apnea? Mm-hmm. Could you have depression, anxiety? If you had severe COVID, could you have PTSD or a post-ICU syndrome, which involves a lot of symptoms of PTSD? Because all of those things are treatable. I look at those cases as sort of, there's sort of a chain of problems that are leading to someone's clinical presentation. Some of those links are just what they are. I can't do anything about having had the COVID infection. There's no treatment for that per se. That's an event that happened.
Right.
But you can treat headache, you can treat sleep, you can treat mood, you can treat all of those things. And taking that sort of rehabilitative approach, people can get better and improve symptoms.
So let's expand on that just a little bit here in the last minute or so. Let's say my brain scan's okay and my neuropsychology testing looks pretty good, like about what it should, and we can't really find anything else, but I still feel really tired and I get this brain fog. And what kind of things would you recommend to help?
So if fatigue is a really prominent thing, I might work with someone's primary doc to make sure they're not experiencing any hormonal changes, hypothyroidism, other common causes of fatigue that could be going on. I would try to get them into a rehab-based program for sort of cognitive rehabilitation, as well as maybe physical therapy to help improve their exercise tolerance, exercise capacity.
So you say cognitive rehabilitation, so you can actually help the way people think through that?
Yeah, absolutely. And you can there are some things that help the way you think, but there are other things that are not designed to help restore function, but just sort of help you do better with the problems that you have.
Yeah, or make lists to keep memory and things like that.
Exactly.
Things that we all do anyway. So this has really been fascinating. I and hopefully people find it useful in helping explain some of the things that are out there. Any questions from the group for Dr. Bateman or me?
I've got some. For Dr. Bateman, I know you touched on this already, but how common are these lingering neurological psychiatric side effects, and are you seeing it at Wake Forest or locally?
So we are. I think you see it. Places that had sort of higher peaks in the wave of COVID are seeing it more commonly or just more frequently. It's I don't know the exact prevalence. I don't know the exact percentage, but of all the people that had COVID, it's a relatively small amount, in the single-digit percentages, I would think. But I don't know that for certain.
And are you seeing it here locally,
So yes, we do have patients that are referred for that. I am certainly aware of people that are. I believe there is a post-COVID clinic at Wake Forest. There's also one at some of the other medical centers in the state. So we are certainly seeing those problems.
So we had someone comment and said that they had COVID in the middle of October. They lost their taste and their smell right away. They got the infusion, but they ended up having to go to the ER. They are having hair loss, and they still are smelling like that smoke, like the parosmia smell. And they wanted to know if these symptoms will ever go away, if there's anything they can do. Yeah,
that's a great question. it's hard to know in any individual person, if symptoms are going to improve. We know that in a lot of people they do, and there can be delayed improvement. There are people that, have had symptoms for weeks and months that then do go on to improve. It takes the nervous system a long time to recover if there's a real injury to, say, those smell neurons, those smell cells. There's nothing that I'm aware of that's been shown at this point to help. So there's no specific therapy for those things. That's one of the more frustrating parts, is that when people come to us and they ask us for advice, for a lot of these things we're kind of stuck with, we just really don't know what's going to help.
There's a study out of England that suggests that if you've not been vaccinated, and or booster if you have, can help speed up recovery of smell and help with some of the other symptoms. It kind of makes sense a little bit, because it almost is like hitting the reset button on the immune system. So that's one thing that we do recommend, in addition to some of the other things that Dr. Bateman described. But sometimes it does take a while. It can even be a year. But that plastic brain can sometimes reorganize and how the neurons interact in the brain. And I think people do improve with time.
We have the question about, do you have any thoughts? Do you know anything about long-term COVID, like long COVID and future risks of dementia? Is there a tie there? What is it?
So
Yeah,
it's
good question.
it's a very so unfortunately, this is another one of those things we don't fully know. It's sort of a topic over the past couple of years at a lot of our major Alzheimer's disease and cognitive disorders conferences. There is certainly impacting the structure of the brain, like that study we talked about, makes everybody concerned that there could be downstream consequences. We just don't know yet. It's not been long enough to know that. We do see people, I certainly see people who come to see me for a dementia evaluation, and they say, well, the symptoms started after COVID. In that case, it's almost never, in no case that I've seen, can I say, oh, well, the COVID caused that. It's usually more of an unmasking phenomenon. Most of these diseases are developing over years before symptoms begin. And certainly an event like a COVID infection, but also like any other infection or even surgery, can sometimes just unmask that and make the symptoms more obvious to people.
So, all right, we'll go ahead and wrap up. One more.
You, Dr. Ohl, if that's okay.
Yeah.
The mask mandates are ending and cases are way down. Are we nearing the end of the pandemic, and are you optimistic where things stand?
Yeah. So we, I think, we talked a little bit about earlier. Optimistic, yes, because things will continue to get better. And we're going to have to ride some waves. But I think the worst waves will be behind us. The level of immunity of our population is just getting to such a point now, even with variants coming along, we'll be able to tamp them down better. But is the pandemic ending? It's going to slide into an endemic infection. Technically, as long as there's increased numbers of COVID happening across the world, we still call it a pandemic. But the face of the pandemic is changing. And the impacts of subsequent waves as they come are going to be less. The things that we're going to have to do to keep it from being a significant problem in our society will become less and less. So we won't have to do as much. So it's sliding into a normal part of what we'll be dealing with. We won't be thinking about it every day.
And as things improve, what do you think individual health officials should focus on now moving forward?
Yeah, I think the big thing is to keep our vulnerable populations safe, because people with underlying health conditions people with who are older and people who are immunocompromised are going to be at higher risk still for having severe problems with COVID, just like they are with flu. And for every year we spend a lot of time trying to help those people get through the flu season or through any respiratory viral season. So I think the focus will be on there. And then as far as monitoring, we're going to be watching a lot more what's going on with the numbers of people getting admitted to the hospital. Because frankly, having a whole bunch of people get colds is not really a big deal. But having a whole bunch of people get so sick that they have to come to the hospital for oxygen and have what pneumonia is. So those will be the things we'll be looking for. All right, we'll see everybody in 2 weeks, and enjoy spring.